today. It's going to be a great few days on learning more about the business case of data sharing and making sure that all things about the future are thought about with this regard. I'd really like to welcome you and thank you for coming. I'm Leslie Kelly Hall from Engaging Patient Strategy. And a little bit about me. I'm a former Chief Information Officer and Chief Marketing Officer. I sit on the Direct Trust Board, also on the Care Quality Steering Committee. I'm involved with patient advocacy and health information technology and spend most of my time making sure that patients are not left out of care and business and the digital world. So welcome and thank you. And Vince, a little bit about yourself and a welcome from you too.
Okay, well, good morning all and welcome. We have an incredible lineup for you for the next couple of days. I'm going to give you a preview of day number one. I'm Vince Kuraitis. I've been a healthcare consultant for the last 20 plus years and work with companies around connecting the various different silos of healthcare, tech companies, healthcare companies across the spectrum. Here's a preview of what we're going to see today. Les and I will be doing the initial keynote presentation today. And then Devin McGraw is going to talk about interoperability in the new normal. Another keynote session, Matthew Holt. Those of you who know Matthew, he can be a little contrarian. And today, Matthew is going to be contrarian. He's going to give us a contrarian view of data sharing. And the last keynote is from Ligia Ricciardi, our friend, who is going to talk to you about bringing digital health home for consumers. In between there, we've got a number of panel sessions, one on legal and regulatory issues, another on COVID-19 EHRs and public health data sharing. And then we have at the end of the day, a recap. Les and I will be back and we'll share from you some of the ahas, some synthesis, and some key things that we might have heard or picked up from all the various speakers of the day. So I'm going to put us into presentation mode and we can begin our presentation.
As Vince is doing that, a bit of a fun fact. Vince and I were both executives at the same healthcare system many years ago. So we've known each other for a long time. And both of us been advocates for data sharing and interoperability since that time.
Okay, and it's fun to work with you, Les. Thanks. So here's the title of our presentation. Patient data sharing, not hoarding, is the new normal. Okay, so let me get up my speaker notes. And the first slide is yours, Les. Can you see the slide number 2? Okay, go for it.
You bet. So Vince and I, several years ago, started to talk about the business cases of data and how data was used. And we know that, in fact, data hoarding doesn't work. And today, we're going to talk about the 7 original reasons why we believe, and the facts and research demonstrate that data hoarding is not a good business strategy. We'll also talk about one we're adding, an 8th, which is that data sharing is critical to access new revenue sources and new margin opportunities. So data sharing is really not just about liquidity of data, but liquidity of margin.
Thanks, Les. Okay, in this slide presentation, we've built in for you some visual cues. When we talk about why hoarding is not a good strategy, we'll give you the visual cue looking in the rear view mirror. When we are talking about the future and why data sharing is a good strategy, we built in the visual cue of looking out the windshield. The primary point of view that we're going to be focusing on, not exclusively, but just to give you an orientation of where we're coming from, will be the healthcare provider perspective, largely hospitals, integrated delivery systems, and physicians, and those that support and work with healthcare providers. So that's just an overview of today's point of view. Okay, first, let's establish that hoarding has been a provider strategy in the past. Here's just one survey from the Robert Wood Johnson Foundation. This survey looked at health information exchange executives and asked, which barriers do your customers, hospitals and doctors, perceive about slowing down information exchange? 83% listed their concerns about competitive position. So again, that's just the rear view mirror perspective. And if you go back to the original article that we wrote, we cite many other examples of why hoarding has actually been a strategy in the past. Okay, Les?
You bet, but data hoarding doesn't work. Some of the assumptions that we have just don't fly. People go to more than one health system, and we assume that patients are loyal and that hoarding data locks in the patients, but really patients move, and our health systems are highly leaky, and patients are readily go across and move among more than one health system. So we believe that this idea is a 90s idea and just not going forward. The assumptions simply don't work. But we do know that patient retention is a critical strategy, but there are many facets to patient retention, and we know that 2/3 of patients would switch to hospitals that share their data. And the key word there is share, not hoard. So we have a desire to know, and we assume that data about us that's important to our care is there, but we don't necessarily have that great customer services yet.
So let's take a view out the windshield and look at some examples where there are data strategies that can build patient affinity. Patient affinity is certainly a viable and necessary goal within healthcare delivery systems, but it's how you do it. One is high performance provider networks, and look at how this has evolved just quickly over the last decade. We started about 10 years ago with narrow networks that were built exclusively off of price. The value proposition was health plan would offer you, provider, a discount in exchange for more patient volume. About 2015, this began to evolve to the health plans and employers picking the higher quality providers. But the data to pick higher quality providers is really fairly thin. Where this is evolving to, and if you look out the windshield, is that the high performance networks are really not only picking the high performance providers, but also helping them out, building systems where they are given the right data to take care of patients, and they're given feedback about their performance. It's a cycle of continuous improvement. Another example is the all-payer claims database analyses. Now, APCDs, if you're unfamiliar with them, are available in more than half the states, but they're not available everywhere. And APCDs, everyone contributes, all the providers contribute data, and they have claims data from the providers and the health plans. And what this allows is for providers and others to get exact metrics on present and future market share. Then once you know where you are, you can develop a comprehensive patient retention strategy. And then as you get back data over time from the APCD, you can measure your results and recalibrate your plans. Okay, let's go on to the next slide. Les?
Our second premise is that convenience is king, and it is. We know in many different strategies, but there is a disconnect. The C-suite might be thinking, if I have all the data or hoard all the data, retain all the data about a patient, and use that as a retention strategy, The marketing group is saying, no, actually, in fact, convenience is everything. Convenience refers not only to the wait time, it refers to things like, is it easy for me to do business with them? Do they have the data needed for me to want to be here? Patients don't think I'm going to go to the ER because they have all my clinical data. They do think I'll go to the ER because it's easy, it's convenient, I don't have to re-explain myself, and it's available and easy. But patients also acknowledge, and this does need changing in the future, that the doctors doesn't have all the information I want them to have about me. They don't share their data even internally. I go to the clinic and the emergency room doesn't have it. I go to the hospital and they don't have anything from the clinic. And they don't use the data to take care of me. In fact, there is an expectation that it's inconvenient, that the data that's currently held is inconvenient to the patient. And there is a very low expectation in terms of data knowledge and sharing and use. So the advisory board looked at some studies of 4,000 patients, and the top 10, 6 of the top 10 primary care attributes were all related to access and convenience. So convenience is king. So we think in the future, I do want to go to the hospital because they know me, I know them, and that they have all the data necessary to my care because they have all of my data. Now that sounds like hoarding, but it's not. It actually means the data has been shared and that the hospital or health system has the data as a patient that I want them to have, that's helpful to my care and my overall health, that helps to coordinate care, to inform and engage me. So raises the expectation level of customer service and convenience by making sure that the data helps me as a patient get better outcomes, better health and care.
Okay, the third reason why hoarding doesn't work is because loyalty, patient loyalty is declining and patient shopping is actually increasing. Again, we quote you from the Healthcare Advisory Board, a major consulting and information company that works with large delivery systems. They measured patient loyalty to primary care physicians, and the statistics are here on the slide. I'm not going to read all of them, but for example, I'll just go over the first one. Only 53% of patients would stay with their current primary care physician for the next 12 months. And think about what's happened with COVID, with the rise of telehealth as an option, where you no longer even have to wait a couple days, a week, a month to see your primary care physician. You can see a primary care physician in the next 30 minutes. So the headline again, loyalty declining, shopping is increasing. However, there is, and here's where we walk a fine line, and the cues hopefully will help you. We're saying in the past, loyalty has been declining, but that doesn't mean that looking out the windshield at loyalty is a bad strategy. And in fact, we think it's a very viable strategy, but it's dependent upon having the right data for the future. It's a long-term strategy. It's an extension of a patient retention strategy. The metric that has been foreign to healthcare is LTV, the lifetime value of a customer. Many other industries think about that in an economic sense. This customer, for example, I recently switched my phone carrier when I was talking with Verizon, my old carrier. The representative told me, well, Mr. Kuraitis, you've been with us for 16 years. They not only have that metric, they provide it to their customer service representatives. Healthcare has never thought this way. And the reason for that, Les, the third bullet point.
Yeah, it's all about relationships, not transactions. So I did some work with a health system that I interviewed about 170 doctors, patients, providers, clergy, administrators, and others all involved in the ecosystem of health. And the we looked at the ideal patient-physician relationship and physician-patient relationship in both points of view. And the outcome of this research was that providers were longing to provide good care and patients were longing to have somebody that cared about them. And it showed that, in fact, what we want to have is relationship. We want to have relationships with those that care for us in a way that is a long time, or as Vince indicated, a lifetime value of a customer. And that's synergy. It's I've got your back, you have my back. In order to have a complete experience as a customer, you have to feel connected. You have to have relationship. And so our data in the past, looking in the rearview mirror, has all been around transactions and not about building relationships, which the only way you build relationships is to share data and be transparent.
Okay. The fourth reason why hoarding is not an effective strategy is that providers have a decreasingly small share of patient data. Healthcare providers assume that they have a lot of patient data. Again, wrong. They have only a small sliver of the total picture of a patient. So what we've done in this slide is adapt some McKinsey data. Let me explain where we are, and I'll explain it over the next couple of slides. The box in the middle of the slide shows 1,100 terabytes, and that's representative of a lifetime of a patient's, you as a patient, with 1,100 terabytes of healthcare data. So let's break this down into how much of this is actually held by providers. Okay, look at the very small green cube in the bottom left of the rectangle. Of the 1,100 terabytes of your healthcare data, only 0.4 terabytes are clinical data, the kind of data typically residing in an electronic healthcare record. But what about the rest of the data? The blue then represents other healthcare data. And to give you, for those of you who are more numerically oriented, there is 2,757 times more of the blue than there is of the green, more data related to factors other than what's in your electronic health record. The blue represents social determinants of health, health behaviors, non-modifiable factors. And if you think about it, here's some examples of the kind of data that is emerging and is prevalent in the blue area. Data coming from thermometers, pulse oximeters, blood pressure cuffs that you have at home, appliances, fitness equipment, cameras, activities about your weight, your health status, food purchases, viewing habits, all of that. And then health apps, of which there are 325,000 various types of healthcare apps. So the punchline, Les.
Yep, I think the punchline really is that all of that blue represents not only the data you don't have, but the risk you have as a provider for not knowing. What we don't know is actually what will hurt us, especially as we move more from fee-for-service to value-based care. And so the access to that data needs to be broad and wide for both clinical and non-clinical data. As Vince said, I think the future will be a relevance engine of some kind that allows people to actually increase their intellectual capital when using a system by being able to query things that are relevant for that patient. For instance, it might be, when has this patient showed this symptom in the past? How has this anatomy been reviewed in the past? What does the patient's lifestyle look like? So our ability to be profoundly different and more have better outcomes will be around the access to and use of clinical and non-clinical data. Vince, you've got some examples.
cue me, Les?
I
Missed you
just
on.
said you have examples of good and bad uses of data.
Okay, so
The
let's
next
go on to
slide.
the next slide. Okay, thank you. So the fifth reason why hoarding is a bad strategy is as healthcare providers, you don't want to become a lightning rod in the Techlash backlash. Techlash is a term, it's emerged a couple of years ago, and it reflects concerns over privacy, data protection, and monopoly powers, primarily through big tech companies. So far, Techlash mostly has not been about healthcare data, but it is becoming that way. And this headline from the Wall Street Journal is the kind of headline that you as a healthcare provider do not want about you. This was about a year ago, and we haven't heard a whole lot about what's happened here. This has not gone away, largely because COVID has overshadowed everything else. But as a result of this headline, Google and Ascension Healthcare, the second largest healthcare system in the country, took a tongue lashing from congressional leaders. They instigated an OCR, Office of Civil Rights investigation, and lots of criticism from privacy advocates. And what Ascension did was they shared patient identified data, which is legal because Google is a business associate, but probably not necessarily a very wise PR move. The headline is really providers should not treat patient data as their asset. So we've given you a negative example. Here's a more positive example. And it raises a whole new value proposition looking again out the windshield where protecting privacy of patient data is becoming a differentiator. A positive headline, Mayo developed a partnership and investment with a startup company called Inference. They use a federated learning technology to protect patient privacy. And in a very brief explanation, what federated learning, typically in a data process, data is centralized and then an algorithm is run on that data. With federated learning technology, the opposite occurs, and the data continues to arise and sit on individual servers, but it's the algorithms that in turn go out and patient privacy is protected. This is really a bipartisan issue, and we expect to see, particularly under a Democratic regime, a federal push against big tech, antitrust, the possibility of federal privacy legislation. Okay. Les?
So thanks, Vince, beyond all of those points, it's really the law and policy now. We're moving from an era of a bias towards security to a bias towards responsible sharing. And I think there is nothing left to debate. It is the law. The info blocking rules have made it quite clear that we're moving to this responsible sharing. We do have work to do. The non-HIPAA data is still largely unprotected. We've addressed that through good consent and model privacy notice, but it's still, we have a culture that assumes private data is private. And so we have new learning to do, and potentially they'll come from new regulation. As Vince indicated, the movement in this new administration is likely to focus on the data liquidity for the benefit of patients and not data liquidity for the benefit of companies. So we think that this will be a continued emphasis. Thankfully, we have a lot of great groundwork that was done previously with work on the Blue Button and the Blue Button 2.0 and view, download, and transmit, and all of these wonderful new opportunities for patients to get access to data. The next logical step is for patients to be able to provide data for patient-generated health data. We'll learn more about that today as well. So sharing responsibly is our key for the future.
Les?
I'm sorry. So as financial risk is increasingly shifted to providers, it's what we don't know or what providers don't know that hurts us. So remember that 60+% of ACO specialty referrals went to out-of-network providers. So we have a little bit of whack-a-mole going on with patients popping up in different places. And it's at the risk now has shifted. So how we manage is that risk is making information transparent, making sure that no one flies blind. So without the best data, patients' care and payment risk when out of network becomes riskier. So we need to know and we need to share.
I'll add the punchline here. So if you're a provider, unless you share data and have others' data, your patients are at risk and your payments are at risk. It's in your financial interests to be sharing data in a value-based care world. Okay, Les, last point's yours here.
You bet. So we also see that the brute force of telehealth and COVID has actually had us all look about what can be done with virtual care, because it's not going to go away. People are very satisfied in general of the use of telehealth as an option, but it can be virtualized in many other places. And this means new revenue sources or new margin opportunities. So the potential that McKinsey's study shows is $250 billion in care can be moved to virtual care. This reduces our costs and also has opportunities for a new digital front door. What we've learned from COVID is it has exposed the actual weaknesses in fee-for-service, in that there's a lot of instability in revenue and margin when customers go away. So we need to stabilize the data, stabilize the provider revenues, move to value-based care that is dependent upon data. So we believe that in this particular article that McKinsey cites, we totally agree that virtual care will be something of the future. For a great example is, if you were a healthcare system and wanted to implement a clinic in a new physical location, what would drive people there? Or do you need the there at all? Are there ways to have new and excellent resources available to your patients that drives loyalty, adds to convenience, increases data liquidity, and allows for the transparency that's needed to build relationship? So we'll be looking at bricks and mortar quite differently as we evolve to more virtual care. Cleveland Clinic's example, they do a great job of an expert second opinion offering for people anywhere in the world. And there's more. Mayo provides great services, and we see more and more taking advantage of virtual care, not only in their physical region, but also across the country and even the world. And Vince, go ahead.
Okay, our ending slide. We're going to try and shift this to a little bit more of a personal note. Think back to a time when you were newly in love, when you were walking on clouds, when you thought the person you were in love with was the best person that you've ever met in the world. The chances are that you shared intimate personal details about yourself. And in turn, that the person you were in love with was doing the same thing, that they were sharing intimate personal details about themselves. And that's what fostered a lot of the love on a personal level, or to jump to a more business relationship. That kind of sharing is what can engender and spark a partnership. If you hadn't shared that, what are the chances that you would have developed that type of relationship? And we think that's a good way to begin to think about the idea of sharing data versus hoarding data. Any 2 cents from you there, Les?
Well, as a woman who recently got married on Zoom, technology and love are not mutually exclusive. But I think that the key point here is that moving from transactional-based data use to relationship fostering data use is the key to the future. And I think with that, we're ready to wrap up. What do you say, Vince?
Okay. So that's it, folks. That's our presentation. We'll be out of here in just a couple of seconds. The next speaker is our longtime colleague, Devin McGraw, a renowned attorney, a privacy advocate. She's going to talk about the legal landscape for interoperability and define what's going on about the specifics of the Cures Act and the legislation that came down earlier, or the rules that came down earlier this year from ONC and from HHS. So we will thank you all for listening and participating. Hope you're enjoying the conference. Any final words from you, Les?
No, just make sure you click on the join this session for the next meeting. Thank you, everybody. Have a good one.
Take care.